So the entire talk of this topic, my talk will be divided into following parts. So with a background of what is aneuploidy screening, it is any deviation of the routine 46 number of chromosomes is what is known as aneuploidy. So there are two karyotypes. Individual A has a normal karyotype and individual B has a free trisomy 21. Everyone can see this. So these are three prototype pictures of trisomy 21, trisomy 13 and trisomy 18, the clenched fist. And overall, the incidence of chromosomal defect in children at birth is roughly 0.5% of all the birth is contributes to chromosomal defect. So what we daily encounter in the OPDs is such a scenario. A pregnant patient coming with these two reports, almost everyone once daily or in a week encounters such kind of a patient. The ultrasound is, the NTNB scan is normal, and they have a positive dual marker report with low PAPase and high HCG. And then accordingly, we give the further options of the non-invasive testings, the NIPT, or the invasive diagnostic invasive testings. So out of these, within the green parentheses, these are screening tests, and these among the red box is the confirmatory testing. So a screening test is basically, whether you apply it to medical science or to any field, it's basically to identify or broadly group the population into two groups, the high risk and the low risk group. The high risk group needs further testing to further confirmatory testing to clear whatever the risk is. So all these screening tests, they are always associated with false negatives and false positives. So this should be clear that it is not the confirmatory test, and these tests do not diagnose a problem. They only signal that further testing should be done. The prenatal screening options available for aneuploidy screening are the maternal age and the background history of the family. Suppose a couple comes with a history that they have a first child who is Down syndrome. So that history itself makes them high risk and increases their risk from one with the maternal background age risk to as high as 1 in 100, because what we say in a free trisomy 21 Down syndrome child, the risk in the next pregnancy or the subsequent pregnancies is 1%. So actually they don't need any screening test, and they should be advised or offered straight away the diagnostic testing. So this is important. A previous history or the background history is important. Age, we all know with the increasing maternal age, the risk of having a Down syndrome child increases, and the basis for this is the increased rate of meiotic non-disjunction in the aging oocytes. Then the second screening option are the serum markers. So we have different serum markers in the first trimester and in the second trimesters. We have ultrasound markers in the form of NTNB scans and anomaly scans. And then there is combination of both the serum and the ultrasound markers. Then this is the latest one, the cell-free DNA based test, or actually it's a screening, not a test. So, and according to all these four options, and the background of the patient or the past obstetric history, we do the further counseling and accordingly the invasive testing. So all these options can be applied to first trimester as well as in the second trimester. So now what excuse me. Okay. So I'm audible now?
Ma'am, you are audible. Ma'am, you are audible. There is no issues at all.
Okay. So the international different guidelines by RCOG, ACOG, Society of Fetal Medicine, they have in various years since almost since 2009, the first guideline was given by RCOG, that they say that regardless of the maternal age, the universal aneuploidy screening is recommended, and this screening should be offered, not ordered, with a proper pre-test counseling of what we are going to do or what these tests suggest to the patient. And the recent ACMG also gave a similar kind of a guideline that to all women, regardless of maternal age, give options of invasive diagnostic testing. If they decline, then offer them screening test. If they decline the screening test also, properly document the reason for declining on your prescription, so that you safeguard yourself. That is important. So what is the scenario at our own country? So FOGSI with ICOG gave the recommendation in 2013 under the routine antenatal care for healthy pregnant women that besides the basic essential antenatal care, the following should be preferably offered if easily available, and that the third point includes the counseling and the screening for thalassemia and the Down syndrome. This was way behind in 2013. So in 2017, the FOGSI Times of Gynae conclave of decision tree algorithm under these moderators, they recommended in the routine antenatal checkup list that dating scan along with NT scan and double marker is actually to be offered to every woman, whether they opt or not opt, that is their decision making. But as a obstetrician, we have to offer. So what all to be tell in the pre-test information? That it's a screening test. It will tell only, or it will detect or try to detect certain common chromosomal disorders. If these tests turn out to be positive, we further need confirmatory testing and then give them the information regarding the availability of the confirmatory testing, their cost, etc. And after all, everything beside this is that no intrauterine treatment is available. So we are talking so much about it. So PCP and DT and the government of India, they amended the MTP guidelines also in this March 2021, and that stated that they have extended the permissible period for abortion from 20 weeks to 24 weeks if at least 2 doctors believe that the pregnancy involves a substantial risk to the mother or the child, or if there are substantial fetal abnormalities. So under this amended law, we should, although this has been taken up or have been started applying by many obstetricians, but still some are skeptical, and according the state laws are also acting in between it. So we as per the previous guidelines, we try to cover up all the tests before 20 weeks so that the family can legally take any decision if required. So with this background, we move on to the individual aneuploidy screening markers. And the first one are the ultrasound markers. So we try to look for aneuploidy. We specifically look for soft markers that are not themselves anomalies, but that occur more commonly in Down syndrome fetuses. So each of these soft markers have their own, strength, or what we called it as likelihood ratio in deciding how far the risk increases or decreases with their presence or absence. So this is what is the basis for ultrasound screening for Down syndrome, or we commonly called it as a genetic sonogram. And according to the different likelihood ratios of different markers, we further change or modify the a priori risk of the biochemical one or the age risk. So first trimester ultrasound markers are the antenuchal translucency and the nasal bone, the tricuspid regurgitation, and the ductus venosus flows. In the second trimester, we have wide range of aneuploidy, soft markers, and there are sets for trisomy 21 different, trisomy 18 different, but in all, they are pylectasis, the increased nuchal fold, choroid plexus cyst, aberrant right subclavian artery, echogenic cardiac focus, single umbilical artery, the echogenic bowel, and the ventriculomegaly, especially the borderline ventriculomegaly is more commonly associated with aneuploidy rather than moderate or severe grade that are more associated with PNS malformation. So whenever we encounter an isolated soft marker, further management depends upon which marker is in question and what is its likelihood ratio. If echogenic focus, cardiac focus is there, short long bones or mild pylectasis, isolated, there is no increase or decrease in the risk for Down syndrome from the pre-scan risk. But if it is isolated, increased nuchal fold thickness or a small nasal bone or ventricular or echogenic bowel, the likelihood ratio is quite high, and hence invasive testing is offered. if it is more than one marker, whatever be the likelihood ratio, more than one marker is a straightaway indication for invasive testing and it should be offered. So up to 60% of Down syndrome fetuses will have a marker, therefore 40% will have a normal ultrasound. So with this fact, the ACOG gave the guidelines in 2012 that second trimester ultrasound alone is the least effective primary screening test for Down syndrome, detecting only 50 to 60% of the affected fetuses. So this should not be alone taken as the criteria of screening the patients into the high risk or the low risk group. And see, I feel this is itself a different topic of talking in detail about NT, but with the background that NT should be measured in the mid-SAG position at a CRL of 45 to 84 between 11 to 13 weeks, 6 days of gestation, with fetus occupying 3/4 of the screen, with proper placement of the calipers, and more than one measurement should be taken. So less than 3 mm is either we take as one criteria, but most common is, or the most authentic is, more than 95th centile of the value of NT for that gestation age for a specific population is considered to be a high one. And increased NT is an indication for further invasive testing and not for termination. Coming on to serum markers, we have the first trimester and the second trimester markers for dual marker and the triple and quadruple marker test. So the source of these markers is the alpha fetoprotein. It comes from the fetal liver, the unconjugated estriol from the fetal adrenals, while rest of the markers, most of them come from the placenta. So some technical guidelines were also laid by the ACMG in 2009 regarding the collection of the samples, their cold chain maintenance, the vials and everything. So overall, on a gross shell, they can be collected either in the form of serum, whole blood serum, or in the form of dried blood spot. So every option has its own plus and minus, but the most temperature sensitive is the human chorionic gonadotrophin, and which is the free beta hCG, which is the most sensitive one, but it is sensitive to temperatures also. So the transport and all becomes difficult at the same temperature. So most of the labs, they are taking total beta hCG into calculations. And what the ideal recommendation is to centrifuge the sample and separate the serum, which can be kept for 6 to 7 days at 4 degrees Celsius without any change of the markers. So the reports or the values of the markers should be strictly reported in multiple of medians or the moms, and they vary with the gestational age, the assay method used, and the population tested. And definitely they need adjustment if the weight is more, ethnic background, the diabetic and the renal status of the mother, if it is more than one pregnancy or the twin pregnancy, if it is an IVF one, or if there is history of vaginal bleeding, the modification is required in calculation of the moms. So we cannot, as manually, we cannot calculate the moms on the individual level basis, and a software is required to calculate the combined risk. Sorry. So there are different, timings and different studies. They indicate when to collect the sample at what weeks of gestation, and accordingly the detection rate varies. So after all the literature combination, the final review, what is practically can be, followed and that can be practiced in an OPD is the OSCAR regimen, or the one-stop clinic for risk assessment, in which at 12 weeks around we call the patient, we go ask her for an NT-NV scan. That is also the right time for that scan, and the right time and the probably reasonably good time for collection of the serum sample. And this together gives a detection rate of 90% with a false positive rate of 5%. So this is a report of a first trimester double marker test. So the encircled regions are the points where we have to stress upon whenever we see such kind of a report, depending upon the date of birth that is taken, the age at the delivery, the NT scan, where it was done, and how important it was, whether it was done according to the NT was taken according to the FMF guidelines or not, what were the moms of the individual, PAPA and HCG, the weight of the patient, whether it was IVF conception, whether she has diabetes and all these, and then the individual risk, the alone one, the biochemical with age, and the combined with NT, what are the individual values. So this graph is, and we have different forms of graphs depending upon the platform used by that lab, the Prisca or the Delphia platforms. So this Prisca, which we most commonly encounter in the OPDs, so it is just like a traffic signal. If it's a green signal, we have to, continue the, or the with the same report and no need for further testing. The yellow is the intermediate region and the red is the high risk region. Then besides these moms, they indicate about fetal aneuploidies. Apart from this, they also give us an idea about the preeclampsia or the prediction about preeclampsia and other bad obstetrical outcomes in forms of miscarriage, stillbirth, and small for gestational age. So these are other advantages of the biochemical markers which help us to guide. So as the age-old criteria of dividing the patients into high risk, intermediate, and low risk group depending upon the values 1:2. So these are on the basis of biochemical markers. And if we have the risk more than 1 in 250, straight away go for invasive prenatal diagnosis or offer prenatal invasive testing. For low risk group, routine follow-up, no intervention. But the intermediate group, we have to look into the ultrasound markers. So and accordingly modify the risk. If now the risk is in the low risk group, further nothing to be done, and routine follow-up. And if the high risk group, invasive testing needs to be further proceeded. So the IJOG gave a sort of slightly different guideline in 2015 when NIPT had come in on commercial basis. So if risk is more than 1 in 100, we can offer both NIPT or invasive testing depending upon the associated ultrasound marker. So if NT is high, we have to go for invasive testing. But if the NT is normal, we can offer NIPT and or invasive, whatever the patient wish for. If it is between 1 in that is the intermediate risk, we offer NIPT, and anything beyond 1 in 2500, no further testing is needed. The quadruple markers, they definitely tell about the common aneuploidies, but besides that, the biggest thing, they provide us an idea about the neural tube defect. So that is the additional what they provide on this from the second trimester, or the quadruple or the triple test. So this is the prototype of a report of a triple and a quadruple report. So the difference is in the one serum marker, the inhibin A is included in the quadruple one. So we have to look definitely for age. Like in this example, the difference of just a 2 month in the age of the patient makes the difference in the risk from 1 in, it increases from 1 in 1044 to 1020. So just a small example how important the date of birth is. So we should always ask our staff who is filling the TRF to ask the biological age of the mother, and not the Aadhaar card or the different ID cards age, because that may vary from the biological age. So that is important. And we should then look into the graph. So this graph is basically for only trisomy 21 and not trisomy 18, or not for neural tube defect. So in a busy OPD, don't just look into the graph only. We should look the report in total entirely. Like this triple test is showing high risk for neural tube defect, which you may miss if you just see the graph. So this is important while taking care of or reading a report. So interpretation of quadruple and or a triple report is all the chemicals are in the low mom range, we suspect trisomy 18. If the HCG high is and the other two are low, we suspect trisomy 21, and accordingly we offer the further testing of amnio and chromosomal analysis. If isolated AFP is raised and we suspect NTD, first confirm the gestational age. If it is correctly taken into the report, then go for a detailed level 2 scan to rule out a neural tube defect. So the screening approaches can be sequential, integrated, or contingent sequential. So the most commonly what we follow practically is the contingent sequential, in which we try to, if the patient has approached us at the appropriate time in the first trimester, it is always better to go for the first trimester combined dual marker test along with an NT scan. And if it is low risk, there is no need for further testing. If it is in the intermediate range, then we can proceed for a second trimester biochemical screening, especially the integrated one from the same lab. And if it is in the high risk range, straight away the patient should be offered invasive testing. This is what the ACOG guidelines in 2012 state, that the use of multiple screening tests performed independently is not recommended, because it will result in an unacceptably high positive screening rate and could deliver confusing risk estimates to the patient. So different methods of biochemical ultrasound, the NIPT alone, they have their individual detection rates and the false positive rate. So obviously among the top list is the NIPT that has the highest detection rate, and the positive predictive value is also very high. So the practice bulletin latest by the ACOG and Joint Society for Fetal Medicine, Maternal Fetal, it gave that after a negative screening test result, do not offer additional aneuploidy screening test, as it increases the potential for a false positive test result. Women with first trimester negative screening should be offered second trimester assessment for open NTDs by ultrasound, or if required, somebody is doubting that in small NTDs being missed, or then they can go for a maternal serum alpha fetoprotein or both, and definitely an anomaly scan. Women with a positive aneuploidy screening test result should be offered further detailed counseling and confirmatory testing. So NIPT, or it should be ideally called a NIPS, or a non-invasive aneuploidy screening, because it's not a confirmatory testing. So I think Dr. Nidhi will cover it beautifully in detail, but just to in short, I will few important points. So it's actually a screening test in which we try to test or extract the cell-free fetal DNA from the maternal plasma, and then by different methods of SNP or MPSS counting based methods, we try to check for the 5 common chromosomal aneuploidies in the fetus. And definitely if it's a positive report, then confirmation is required by the invasive testing. The idea behind NIPS was the potential to reduce the number of invasive procedures throughout the world. So NIPS testing is the testing DNA from the placenta and not the fetus. Therefore, it may not reflect the true fetal karyotype. And there are reasons for the discordancy between the actual karyotype of the fetus and the cfDNA reports, because of true fetal mosaicism, confined placental mosaicism, presence of maternal karyotype abnormality, insufficient counting due to low fetal fraction, and the vanishing twins. So consider these points in the counseling. So potential limitations of NIPS is its accuracy is not that of fetal karyotyping. It cannot replace the invasive testing or the confirmatory testing. The karyotype additionally provides other informations also. It does not screen for open neural tube defects or late pregnancy complications, and it is not shown to be reliable in multiple pregnancies. So all these points should be covered in the pre-test counseling, that it is just for 5 chromosome. It's not a diagnostic test. It requires invasive testing. If it's positive, you should see before offering whether the family history, any background additional, baby of mental retardation or anything, then NIPT alone will not help. So better to go for invasive testing and the broad karyotype or the microarray. Then in the you should look for the individual reports also of the serum screening. If there are isolated increase AFP and you have ruled out other things, you need to go for filtering of whom to offer NIPT. And negative test result does not ensure an unaffected fetus. And follow up second trimester ultrasound is a must in all cases of screening in any forms. So So the NIPT is not recommended for cases with recurrent miscarriages, because then in that cases any of the couple may be a carrier of valence translocation. If there is family history of genetic disease, then it does not help NIPT. If the ultrasound is showing any malformation, then also NIPT is not to be offered, or if there is increased nuchal translucency or nuchal fold thickness. So ACMG gave this position statement regarding NIPS, that it recommends the offering diagnostic testing for a no-call NIPS result, which is mainly due to due to low fetal fraction, and a repeat blood sample draw is not appropriate. Offering aneuploidy screening other than NIPS if the patient is significantly obese. All labs should include a clearly visible fetal fraction on NIPS reports. All labs should specify the reason for a no-call NIPS report. And all women with a positive cell-free DNA test result should have a diagnostic procedure before any irreversible action such as pregnancy termination is taken. Those women who have a no-call cell-free DNA screening report should receive further genetic counseling and be offered comprehensive and ultrasound evaluation and diagnostic testing because of their more increased risk of aneuploidy. The diagnostic testing, we have amnio and the CVS, but there are scenarios when we don't, like I initially also mentioned, there are no role of screening test. We can offer such families straight away the direct amniocentesis when we have a couple with previous child with already known Down syndrome, previous child with structural chromosomal abnormality, parent is a carrier of chromosomal abnormality, and ultrasound is showing malformation or presence of two soft marker. These are few such indication in which there is no role of screening test, and we should offer straight away the direct in confirmatory testing. And still, the patient should be counseled that normal fetal karyotype does not rule out chromosomal microdeletion, duplications, or single gene disorders. So accordingly, in the amniotic fluid, the test of only karyotype or microarray or a single gene test detection can be offered depending upon the patient's or the family's history. The special situations, the screening in twin pregnancy, the first and the foremost thing is to estimate the chorionicity by ultrasound. That is very important because all the other further steps will be guided by whether they are dichorionic twins or the monochorionic twins, because risk by biochemical screening is calculated for each fetus in case of dichorionic twins based on maternal age and NT, while it is calculated in pregnancy as a whole for monochorionic twins. So dual marker is 70 to 80%. It has a detection rate in twins, while quadruple has just 40 to 60% with more false positive rate, and detection rate is more in monochorionic than dichorionic twins. So twins, the screening efficiency by biochemical markers is low and not as accurate as that in singleton. In multiple pregnancies, that is more than 2 fetuses, combined test is usually not recommended. Vanishing twins, the markers are very high, hence the results are not as accurate, and we should differ from biochemical screening. And in NIPT, the NIPT in twins, it is promising, but currently all the labs have a very limited information. So what the latest guidelines say is that no method of aneuploidy screening is as accurate in twin gestations as it is in singleton. Because of lack of data in higher order multifetal gestations, analyte screening should not be offered. In multifetal gestations, if fetal demise or an anomaly is identified in one fetus, the serum-based aneuploidy screening should be discouraged because of the inaccurate test results. In IVF pregnancy, the screening, we have to keep in mind these points before offering biochemical aneuploidy screening. If it is the donor pregnancy and the donor egg is being taken, so donor age should be taken into consideration for calculations. The markers are a bit different in IVF conceptions because of the different hormonal protocols they have underwent. And in vanishing twins, because it's more high, chances of vanishing twins are high in IVF pregnancy. So the biomarkers are usually increased up to 6 to 8 weeks. So accordingly, you should be careful while ordering for the screening test. NIPS in IVF pregnancy, in donor oocytes, the testing laboratories should always be contacted regarding the validity of the NIPS in their lab before it is offered to the patient as a screening option. So PGS as being offered in the IVF pregnancy, those who have conceived after pre-implantation genetic screening for aneuploidy should be offered aneuploidy screening routinely and diagnosis during the pregnancy, because there are high chances of false negative test results even after PGS. So routine aneuploidy screening should be offered. So the take-home message from all this thing is that pregnant women, regardless of their age, to be offered aneuploidy screening with pre-test. For all pregnant women should be offered. First trimester maternal age along with NT and serum screening gives the best result. Quadruple screen or integrated screen is to be offered if either NT is not available or the patient has contacted you late in the pregnancy. Chorionicity to be determined by ultrasound, that is the first thing in first trimester for all twin pregnancies. Any soft marker is not an indication of termination but further diagnostic testing with counseling. NIPS can be offered to high or low risk women with pre-test and post-test counseling. NIPS only is checking for the 5 common chromosomal aneuploidy and does not diagnose other disorders. All screen positive results should be confirmed by invasive testing, and we should try our all best to offer the test so that they are proceeded and the results come before 20 weeks of gestation. So any questions or
Ma'am, should we take the questions at the end during
okay, fine,
Dr. Glossy
fine.
ma'am's? Okay, perfect.
Fine.
Thank you so much, ma'am. We'll move on to our next topic. The next topic is role of non-invasive prenatal testing in modern era. And our speaker is Dr. Nidhi Jha, who's a senior consultant at NOAA South End Fertility and IVF at New Delhi. With that, I'll hand over the mic to ma'am. Over to you, ma'am. Ma'am, your mic's muted. Can you unmute your mic, ma'am? Yeah.
Thank you very much, all of you, to be here. And thank you very much, Dr. Poonam, for such a deep insight on this vast and difficult topic for all of us. And I feel that I'm privileged to sit here and be in your company. Okay, so my topic for today is non-invasive prenatal testing. I'll be sharing my slides. Just a minute. Second.
Ma'am, are you having problems with the full screen?
Yeah.
Ma'am, you can just press function F5 if you're not able to. Yeah.
Actually, whenever I'm.
Or ma'am, you can click on slideshow. It's.
No. No, I'm sharing the screen. So the topic is role of NIPT in modern era, and very important informations are already shared by Dr. Poonam. So I'll be starting with why is the need, as she has told us that these are the things, these are the trisomies or aneuploidies or chromosomal abnormalities are there, and for that we do these invasive and non-invasive testings. I would like to start with a different angle: age and miscarriage rate. At the age of 30, when a mother is 30, the miscarriage rate is 7 to 15%. When the age of the mother is between 31 to 34%, then the age of miscarriage rate is then the miscarriage rate is 17 to 21%. From the age of 35 to age of 39, it's 17 to 28%. And when the patient is 40 or more than 40, the miscarriage rate goes as high as 40 to 52%. So why are we discussing this miscarriage rate? Miscarriage rate shows first trimester miscarriages are mostly due to aneuploid embryo or genetically abnormal embryos. The percentage of aneuploidies, 10% of eggs are aneuploidic in young women. In women less than 30 years, and she has no other problem, still 10% of eggs are aneuploidic. This tells you about the miscarriages in young women conceived naturally. We are able to see the normal pregnancies, as I'm basically an IVF specialist. So we explain when our IVF conceptions miscarry, we tell them that even my normal conception, young mothers have miscarriages. So don't worry about the miscarriage. You'll become pregnant again and you'll be able to carry the pregnancy further. The basic reason about that is, even if everything is fine, 10% of eggs are aneuploidic. At the age of 40, 30% eggs are aneuploidic. At the age of 43, 50% of the eggs are aneuploidic, and nearly all the eggs are aneuploidic at the age of 45 years. So prevalence of aneuploidy overall, live birth, IUD termination, 1 in 228, 0.4% of the incidence of aneuploidy is 0.4%. Maximum of it is covered by Down syndrome, which is 53%, gradually decreasing. Others is a very important aspect of it. That is 16%, where we are not able to tag it to something. It includes all those. And the third one is trisomy 18, which is 13%. Others are 45, all other aneuploidies, either it is triploidy or quadruploid, anything. So what are the hard facts? Aneuploidies are a major cause of perinatal mortality and morbidity. The most common aneuploidies are the trisomies. The detection of chromosomal abnormalities is common indication for invasive prenatal testing, which is amniocentesis and chorionic villi sampling. Both of these are associated with increased risk of miscarriage. Figo Guidelines 2015, during the past 20 years, non-invasive screening tests have proven of increased utility in prenatal diagnosis. Figo Guidelines 2015 has suggested to use more and more non-invasive screening tests in our day-to-day practice. That's where the NIPT comes. Starting from the history, in the 1970s, the main method of screening for aneuploidies was maternal age, more than 35 years. Maternal serum AFP screening was then widely adopted and had the potential to increase the detection rate. In the late 90s, biochemical markers HCG, unconjugated estradiol, later inhibin A, were discovered. Late 1990s and early 2000s saw the introduction of first trimester screening. Combined test. What is combined test now? This is we do for almost all the patients. Why I say almost all the patients? Because most of my patients are infertility treated patients and they have undergone ART. So this is NT-scan. They are relatively older age group. NT-scan when compared to the spontaneous conception ones. The combined test is NT-scan with dual marker test. Combined is performed between 11 and 13 weeks of gestation. A blood sample is obtained and an ultrasound examination is carried out. A combination of maternal age, fetal nuchal translucency, and 2 pregnancy hormones, which are Papa A and Phi beta HCG, are measured. About the moms and all, already Dr. Poonam has explained you. Triple test is on its way out. It is disfavored these days. Quadruple test. This test generally I offer to the patients who have come to me in the later stage of pregnancy, beyond 13 weeks of the gestation. So can be performed, the positive part of it, it can be performed between 14 weeks to 22 weeks of gestation. The concentration of 4 markers are measured. It's AFP, HCG, and conjugated estradiol and inhibin A. It has detection rate of 80% and false positive rate of 3%, which is a little high. NIPT, here comes the non-invasive prenatal testing. NIPT is the almost latest blood test for Down syndrome and other common aneuploidies and has better results, almost 99.9% accuracy. The presence of fetal cells in maternal blood was initially reported in 1969, and it was able to detect small fragments DNA from the baby in mother's blood, and these small fragments were called cell-free fetal DNA. Cell-free fetal DNA. So, from where these cell-free fetal DNAs come in maternal blood, cells around 1 fetal cell per 1 billion total cells persist between pregnancies. Even between pregnancies, you can see around 1 fetal cell per 1 billion total cells. Cell-free DNA, not fetal per se. Cell-free DNA, it can be maternal, it can be fetal. 150 to 200 base pairs in length by 10 weeks of gestation. 90% of total is maternal, primarily. And where does it come from? It comes primarily from apoptosis of blood cells. 10% is from the pregnancy, primarily from apoptosis of placental cells. Half-life is less than 20 minutes and it is undetectable after 2 hours postpartum. This has been used for years for fetal RHD genotyping. So what are the goals of NIPT? Goals of NIPT, the first and foremost is it should be available to all women. It is their wish or the indications can be decided, but it should be available to all the women. Reduced risk to fetus, reduced anxiety in the mother, increased detection, and reduced false positive rates. Again, coming to the topic, NIPT measures circulating cell-free fetal DNA present in maternal blood from trophoblast, comprises around 10% of DNA in maternal blood, increases with gestational age. Cell-free fetal DNA analysis determines if normal, higher or lower than expected quantity of particular DNA sequence found on selected chromosomes like 13, 18, 21, X and Y, performed on maternal blood sample, and it can be done as early as 10 weeks of gestation. Indication for NIPT, increased risk from prior screening, advanced maternal age, which we have already talked of, 35 years or plus, maternal anxiety as in IVF pregnancy or any other pregnancy where infertility was history prior, previous affected pregnancy, and the most important thing is if the patient is willing and if the patient wants to get it done. Summary of evidence for NIPT. How sensitive and false positive it is. For Down syndrome, it's 99 to 100% sensitive, and false positivity rate is only 0.1%. For trisomy 18, it's 97 to 100%, and false positive rate is 0.1%. Trisomy 13, it's 79 to 92%, and false positive rate is 0.1%. Sex chromosome differences, 94 to 94.9%. As you can see in the table, it's most effective for, most sensitive for Down syndrome, and relatively least significant for trisomy 13. Counseling, as we know, counseling is the key. All factors require need for further reassurance and information prior to a maternal decision around invasive testing. Procedure, as every procedure should be started from consultation and counseling. All these, either it's an invasive procedure or it's an non-invasive procedure. Counseling is the most important part of the procedure. And when should this counseling happen? This counseling should even happen before the antenatal thing. Before the patient, when the patient comes to you, as they come to us as infertile couple or as a normal couple who wants to get pregnant. So everything should be done, started, at least should be started even before they start planning for pregnancies. At least they should be aware of the things which are available now to keep their babies safe inside and outside the womb. So scanned and dated by ultrasound, including fetal number and chorionicity. As Dr. Poonam said, fetal number and chorionicity is very, very important, and it should be done as early as possible, preferably in the first trimester, the earlier part of the first trimester. So how is it done? 2 10 ml maternal venous blood in strect tube, as indicated, consent form, consent and counseling and consultation. In the consultation, consent is the very, very, very important part. The dispatch, the blood sample should be received in the lab within 72 to 96 hours. So here you can see the strect tubes. 2 10 ml of blood is collected in special strect tubes. The important part of it is shaked well. It should be shaked well, mixed well. The result is back within 5 to 12 working days, depending on the lab. High-risk screen results are reported to the healthcare professional and a follow-up is arranged. Counseling and discussion regarding an invasive procedure to confirm the high-risk NIPT results. So your work starts even before the conception, and if someone, you have sent a sample for NIPT and that NIPT has come high risk, because as Dr. Poonam said and as previously discussed, that NIPT is a very sensitive tool, non-invasive tool, but still it is not a diagnostic method. It is just a screening method. So every high risk NIPT or any high risk, as far as other high risk like dual marker and combined screening is abnormal or quadruple screening is abnormal, we should not confirm it with NIPT. It should be confirmed only with the invasive testings. Different technologies are there for NIPT, massive parallel shotgun sequences or sequencing or directed approach. Testing, what are the reasons? Testing beyond common trisomy. When knowledge should be done, patient wants current standard of care. So current standard of care, and if they are willing, you can advise them NIPT. Patient wants, when the patient wants comprehensive genetic evaluation. In this case, if the patient wants full genetic evaluation, whenever if a patient utters to you that they want full genetic evaluation of fetus, there might be multiple reasons. There might be history, a strong family history. There might be advanced maternal age, there might be a full-term IUD because of all these common congenital disorder. There might be a reason when the previous child is affected. Whenever they say, whenever a parent come to you and say that I want full genetic evaluation of fetus, the answer is always invasive testing with microarray. It should not be fulfilled only with NIPT. If the patient wants comprehensive genetic evaluation and the only concern is trisomy 21 or 18 or 13 or sex aneuploidy, still if they want definitive information, you should again go back to invasive testing with karyotype, or they just want safe tests that whenever they want any conclusion that they want to exclude that it's not there and you should guarantee. Whenever a patient comes to you and they ask you, doctor, can you guarantee me that I'll get a normal child by doing this? Don't advise them NIPT, advise them invasive testing. So how do you compare? I'll be comparing the NIPT with these other invasive and non-invasive methods. The timing of chorionic villus sampling is 11 to 13 weeks. Amnio is more than 16 weeks. Sequential is 10 to 22 weeks. And NIPT, as I have already said. Procedure: CVS is invasive, amnio is invasive, sequential is ultrasound and maternal blood. We have talked about dual markers and all. And here it is only maternal blood. Risk: in CVS, it's high risk, 1% of miscarriage risk. In amniocentesis, it's 0.1% miscarriage risk. Sequential, there is no risk to pregnancy because it is non-invasive, and as same with NIPT, non-invasive, so no risk of miscarriages. Sensitivity, more than 99% for aneuploidy in case of CVS, similar with amnio. Sequential, 90% for Down syndrome and more than 98% in NIPT. Specificity, more than 98% for specificity, more than 98% for aneuploidy, more than 99% for aneuploidy, 95% for Down syndrome, more than 99% for Down syndrome. Turnaround is less than 2 weeks, amnio is less than 2 weeks. Sequential takes lesser time. Conclusion, coming to the conclusion, I have kept it short and sweet because the timing was less and I knew that Dr. Poonam is going to take more time. So coming to the conclusions, pregnant women should be given information on the screening test prior to the screening. Screening test should be offered to all pregnant women. They should be provided with an opportunity to discuss with the health professional before making a decision to accept or decline screening. Screening tests do not give a definitive prenatal diagnosis, but to provide a risk probability for a term. Following the screening test, result must be explained to the patient. However, further tests are required to confirm or diagnose a fetal abnormality. One must respect the decision of every pregnant woman. At the end of it, we always want a healthy baby and a happy mother. And with all, thank you very much for your patient listening.
Thank you so much, ma'am. We'll now move on to the question answer moderation. Our moderator for the Q&A moderation is Dr. Glossy Sabharwal, who is a director of radiology at Jeevan Mala Hospital and Apollo Spectre Hospital, New Delhi. Good evening, ma'am. Ma'am, we'll just be sharing the questions that we received on the slides. I hope my screen is visible.
Absolutely, it is. Am I audible?
Yes, ma'am, you're audible, ma'am.
Thank you so much. And thank you, OnQuest team, for bearing with me. My sincere apologies for joining in late because, sometimes babies don't give position, as Dr. Nidhi Jha told. So this level 1 baby and the fetal echo babies were just not turning, and that delayed the whole process. But yes, patient comes first, and that is always the case with all of us. Very important topic, and I'm glad that I was using my headphones to listen to Dr. Poonam and Dr. Nidhi. I think most of the questions have been answered, but we are going to take one by one. The first one is for Dr. Nidhi. 40 years primary gravida at 12 weeks singleton pregnancy conceived after IVF counseling, after IVF, and tests for aneuploidy. Which test do you think should be offered? It's a singleton pregnancy, 40 years. Should we tell the patient to go for double marker? Should we tell the patient to go for NIPT, or only either of the two, or both, or how do we proceed? There are some things which are very, very confusing.
We'll start with the history. Everything starts with the history. The patient is 40 years. She's a primary with age 40 years, 12 week singleton pregnancy. So this age group, the gestation is accurate for both double marker and an NIPT. We can do both at this time. Then after that, it is an IVF pregnancy. And I have to decide about the decide about the test, what test I should offer. Ideally, if in the similar patient, if the age would have been 34 years or 35 years, I would have safely counseled her for double marker. Still, the sensitivity of double marker is 92 to 93%. But in the case where I can give the benefit of doubt, when the age is less than 35 years, I would have asked for, I would have given the options of both, but I would have not recommend that you should go straight away for an NIPT. But in this case, seeing her age and IVF conception, I would advise her NIPT, because as I said, false positivity rate is less and the sensitivity is more. It's around 99%, and with the double marker, it is 92 to 94%, and false positive rate also is a little bit higher. So I would recommend this patient NIPT.
Another question, Dr. Nidhi, do you think that we can forego the NTNB scan and only depend on the NIPT in
Never.
the same?
No, never. Always. We have to go for NTNB scan, and these days are good fetal medicine experts. These NTNB scans are not only NTNB scans, they do almost the early fetal evaluation. So my fetal medicine expert, she says, Dr. Nidhi, if I have seen her in for NTNB scan or 11 to 13 weeks, level 2 will be very easy for me, because I would have seen everything. So it should be taken, and it is taken as early anomaly scan, 11 to 13 weeks. That NTNB scan we used to call it earlier. Now we call it early anomaly scan. Except heart, most of the other things can be seen at this age. So nothing can replace NIPT, is adjunctive to the ultrasound, not without ultrasound.
Absolutely, very nicely put, because this is actually the early anomaly scan, and that is how it should be taken. Thank you so much. The next one goes to Dr. Poonam. Ma'am, are you there?
Yes, I'm audible.
Okay. Yeah. So a 39 years old primary gravida at 10 weeks pregnancy with thalassemia minor in both partners. Now, what tests do you think should be offered? Should we go for invasive or NIPT?
See, as Dr. Nidhi told, we should always start with the history. So she is 39 years, so age itself is a high risk factor for aneuploidy also. And she is the couple is a known thalassemia minor status, they both have. So they have a 25% risk of having a thalassemia major child. So according to combination of both the high risk for aneuploidy as well as for the single gene disorder, that is thalassemia, I feel or what is recommended by guidelines is we should offer them an invasive test, because she's at 10 weeks. We'll go for an NTNB scan, see for the position of the placenta, and give a good pre-test counseling regarding the in both the invasive procedures available, CVS and amnio, the technical expertise available, and then the risk of invasive procedure related risk of miscarriage, and what we are intending to. So in the same, if she goes for a CVS approach, then in the same DNA, fetal DNA, we will go for aneuploidy screening as well as for the thalassemia genetic testing for the HBV gene sequencing. So that is what will be the best approach. And if she has a very posterior placenta, non-approachable one, or the patient is not ready to go for a more invasive procedure like CVS with high risk of miscarriage, not actually high risk, more than that of the amnio. So we can wait till 16 weeks, go for an amniocentesis, and then proceed for both the aneuploidy screening as well as aneuploidy testing as well as the HBV gene sequencing for the thalassemia. So NIPT as such, till present day scenario, has not been validated for single gene disorders for many reasons, and so it is not an advisable test in this situation. That is what it is. In fact, we will straight away go for an NTNB scan and an invasive testing, whatever the patient opts for, whether CVS or MR. There's no role of screening in this.
Okay, thank you so much, Dr. Poonam. That was quite explicit. The next question again goes to you, Dr. Poonam. 28-year-old. Can you see the question? Can you see the question on your screen?
Yes.
With the double marker report as follows, and the NT.7, the risk of trisomy 21 is 1 in 3,445. And ultrasound 19 weeks shows bilateral choroid plexus cyst, and it also shows echogenic cardiac foci. So there are 2 soft markers which are present, and we have got the risk of trisomy 21 on DMT. Now, what do we do next? Amnio or NIPT?
If we look at the individual moms, the PAPE mom is low, the HCG mom is fairly nearly 1. So if I would like to, further ask a question or look into the report of the biochemical risk in this patient of aneuploidy, I feel it would be somewhere in the intermediate range. But it's this 1 in 3, 4, 4, 5 is a combined risk because the NT is within the range. 0.7 mom is making the entire risk going down to 1 in 3,000 something. Above that, if we add on to this information of 2 soft markers for aneuploidy in the level 2 or the anomaly scan, so then together this picture, obviously I will give them the gold standard invasive testing option. That will be the most favorable in this scenario. But yes, a 0.34 PAPE is also low, so we have to keep in mind bad obstetric outcome risks and all. So all these plus and minus issues will be counseled in detail with the patient. If they still don't want to go for invasive testing, then NIPT can be a fair option. But yes, on the first go, I will offer them amniocentesis for chromosomes. That is it.
Okay. So basically, we are giving a cafeteria approach to the patient, that we do, you do either this or we do this. Dr. Poonam, Dr. Nidhi, would you like to add something to this, or you agree with what Dr. Nidhi says? Dr. Poonam says.
Whatever Dr. Poonam says is definitely perfect, because the thing is, I will never see, it's not only the biochemical marker, even the ultrasound markers are there. Biochemical markers are not that bad as Bam says, it's intermediate. But added, although these are the soft markers, but in the view of abnormal biochemical markers, these become significant. So I would, for the first option, I'll give it invasive testing. And even the age in this age was, I think, 39. How much was the age?
29. 29.
29. The age is not significant, but there were both biochemical and ultrasound markers. So I would always advise an invasive thing. But still, if they don't agree, then we have to go for it.
Wonderful. Great. So what is this the next question, or is this the outcome of something because this tells that the baby turned out to be a down. So I think we can move on to the next question, please. can we use maternal blood sample to screen fetus using molecular testing? I believe circulating fetal DNA is easily distinguished from maternal DNA.
I think that's what the NIPT is about.
Yeah, exactly. Yeah, and that's what you've been explaining in your presentations. Is it advisable to do NIPT sample collection at home?
Generally, I am not very comfortable. I think whenever when we offer someone an NIPT, I feel that they should go to the lab and get it done.
Absolutely, even I agree, because the way it is transported is very important.
Just want to add upon to it, the guidelines say that the test that is able to detect the gender of the fetus, then those kinds of tests should always be collected or performed at a center that is PCPNDT registered.
Yes.
So that is what the guidelines say, that it should not be collected from home, because as a part of the policies, if we go for a home collection test, then that means the report should also be delivered there. So that is then the patient will expect that everything should be there. So all as per guidelines, a test that is able to detect gender, it should be taken or collected from clinics or centers that are PCPNDT recommended. So if a obstetrician is practicing in a clinic that does not have a PCPNDT registration, that means that is she's not having a ultrasound or anything, so she also does not have the right to get the NIPT sample collected from their clinic. She always has to send to a center that is PCPNDT registered. So this is what the guidelines say. So as far as I can answer on this, it is not recommended for home collection. Definitely the point that Dr. Nidhi also said, that it has a special cold chain maintenance type of the sample collection, the shaking of the tubes and everything should be under preferably in the guidance of a doctor. But besides that, pardon?
Timing is important, cold chain is important, sampling of blood, I don't know who is getting the blood, whose blood it is, and the report comes to never.
Absolutely. Okay, moving on to the next question. What is the risk of a false positive test for Down syndrome? What precautions to use to avoid that? Dr. Poonam, being a genetic specialist, please, can you tell us that how can one avoid not having a false positive test? NIPT, a false positive. Does it happen? Do you see that in practice?
So, see, this question is actually a bit vague. If you are talking of false positive test for NIPT or false positive test for the other biochemicals, see, false positive test for other biochemical screening is high, but for the NIPT, yes, the chances are very, very remote. But as I told you, as I showed in my slides, there are points where we have discordancy between the NIPT report and the actual karyotype, because whatever we are checking in the cell-free fetal DNA is the DNA source is the placenta. So if there is any mosaicism in the placenta, or if there is any actually mosaic fetus, or is there any mosaicism in the maternal blood, own maternal karyotype. So these are points where there is discordancy between the NIPS report and the the actual karyotype of the baby. So precautions, actually, see, precautions means this is on the technical part of the lab. See, if we have a very low fetal fraction, then the labs usually below 3%, they do not proceed for the test, and they ask for either resampling if the patient is of average build. But if she is obese, it is always better to go straight away for a invasive testing rather than wasting time to collect the sample again, and we know. So these are more on the technical aspect of the lab to judge, and that is why the recommendations is that whenever we see a NIPT report, we should always look into the levels of fetal fraction they have got and on which they have proceeded for the test. And if it is a no call report or anything, then we have to say for the reason. So yes, it's after all, it's a screening test. So there are expected false positive results also, but that are very, very rare in NIPT.
Less than
Okay,
20%.
wonderful. Yeah. Dr. Nidhi, next question to you, ma'am. In quadruple, specificity is 40 to 60%. Is it for all trisomies?
40 to 60% for all trisomies. I think, Dr.
I think this is for twins. This specificity of 40 to 60% is for twins,
It's for twins,
not
yes.
for a singleton pregnancy.
Yeah, it's not for a singleton. Yeah. Okay, next question, please. Is it HCG or free beta HCG to be measured?
See, this I have mentioned in the technical considerations of the sampling in my slides also. See, ideally free beta HCG is the best one and the most sensitive one, but because it's temperature sensitive, so either one should go for a dried blood spot collection, or they should centrifuge the sample, keep it at 4 degrees Celsius, and then transport it to then it is okay. Free beta HCG ideally should be taken into consideration, but because of all these reasons, and India being a tropical country, so we should what is mostly followed is a total beta HCG estimation, and accordingly the mom, especially in quadruple, that is what is being followed for all the labs. I think labs would lab people will answer better in this thing, but yes, it is for on practical.
It is free beta HCG.
Yes, the sensitive one is free beta HCG, but for practical, considering all the practical scenarios, most of the lab are checking total beta HCG. Most
okay. All right. What is the ratio between high risk maternal marker and low risk NIPT test?
I don't get this question actually.
Even I didn't get it. Dr. Nidhi, did you get the question?
No,
that is, I feel the
What
person
is the
wants to ask is where ratio means how many times we get a high risk biochemical aneuploidy result, either in dual or the quadruple, and if we subsequently proceed for a NIPS, how many times we get a low risk. So most of the time we get a low risk one, but we have to, this ratio this is a vague question, but we should look into the moms, the ultrasound markers and everything, then only we can suspect ki isme low aayega NIPT or isme high aayega. So that is, this is a bit nothing like study or a literature as there on this ratio, but what we see in practical scenarios is that most of the time positive biochemical markers result are normal in NIPT. That is what.
Yeah. Next question, why do you think my baby is too risk for, okay, so this question needs to be reframed, whosoever has asked. Please, yeah, there's some either typing error or something. Can we move on to the next question, please? Is NIPT always correct? Maximum duration till when we can perform NIPT for high-risk patient with serum markers? Dr. Nidhi, can you please tell us about this?
NIPT, as usual, I said, and I have said many times, Dr. Poonam has said many times, it's not always correct. Whenever any screen positive is there, it's dual marker screen, quadruple marker screen, or anything suspicious earlier, it should be confirmed with invasive testing, not only with NIPT. And coming to the second part of the question, Dr. Glossy, uske saath added question.
Yeah. Maximum duration till when can we perform this for a high risk? Like till what gestation can we do
Around
it?
22 weeks. 22.
Yeah, that's how we do it. Yeah, perfect. Please brief on the significance of FMF Fetal Medicine Foundation accredited software for double and quadruple markers.
Software lab people.
Lab people, here we need you.
See, the FMF accreditation for double and quadruple markers, what they consider many more points into it. not only NT, they may consider the fetal heart rate, the NB, and the moms, or they may also involve raw data, also the gestation age, the date of birth, everything. But they are they are more validated as far as we can think of, and the labs that are following those guidelines, they are considered to be more, that is what we say, 92% or 94% detection rate or something like this. So that is when the labs are following this FMF guidelines. So FMF guidelines mein collection se leke applying those softwares, everything is important. So like free beta HCG to be used, and the levels of those to be used, the NT to be used on the that is measured on the FMF guidelines only. So that is what the difference is from the routine. So many times those labs that are following the FMF guidelines, if they found that the NT that has accompanied the sample, the report, is not from the radiologist or sonologist who is FMF accredited, they will not incorporate. They will only give the biochemical risks on the basis of just biochemical markers. They will not incorporate NT, and it is the ordering physician's discretion that whether to, according to the sanctity of the NT that has been done, you include or you don't include. So this is what FMF should be followed, because they are the standard guidelines, and one should try to stick to guidelines. Then only less chances of errors and more chances of detection rate are there. That is.
Okay. Some doctors ask for the test inhibin B. This is not included in maternal markers. So what is the utility of inhibin B, Dr. Nidhi?
It's a marker in case of quadruple marker. So when a patient comes to us late, like after 13 weeks of gestation, then we will not be able to do the combined analysis, which is called the dual marker plus NT-NB scan. In those cases, we offer quadruple marker, and inhibin B is the component of it. So it's not wrong when your doctor is offering you inhibin B added with other markers.
Wonderful. Do we have more questions to go?
Ma'am, that's it.
Thank you so much. Okay, there's one question which I can just read in the chat. Triple or quadruple is ideal to do between 14 to 20 weeks, but it is up to 22 weeks. What will be the difference between both?
Triple marker, we don't offer these days. We either go for dual or quadruple. And dual marker, we do it before 13 weeks, 11 to 13 weeks, as we say. Quadruple marker can be done late, up to 21 to 22 weeks. What was the last thing?
What's the difference between the two?
We generally prefer dual marker. Somehow I prefer, I don't know the significance of it, but as early as possible. We like to do everything as early as possible, and it includes an NT-NB scan. That's why I prefer dual marker than quadruple marker. Dr. Poonam, your take on it.
Actually, what Dr. Nidhi said is what is written in the guidelines also. We should the combination of dual marker biochemical plus the NT, or the combined dual marker, has the most sensitivity out of all the available biochemical screening tests. So, and that is used as a triage to further move whether to proceed for straight away invasive one, or an integrated quadruple, or a no testing further. That is what is contingent sequential screening test, contingent screening. So then the question here was whether till 20 weeks or 22 weeks, 6 days, what is the difference in the quad? What I could get, Dr. Glossy, that the question asked was 14 to 20 weeks quadruple is, and 14 to 22 weeks, 6 days quadruple, what's the difference? So it's just the difference in the available softwares and the values, validated values for the weeks that the lab has. If a lab is accepting samples till 20 completed weeks, that is 20 weeks 6 days. That means that lab has validated its data for the levels of the biochemicals for those weeks, till those weeks, and the software is able to calculate. But that lab who has data till 20 weeks 6 days will not accept the sample of 21 weeks 6 days. No, because it does not have that software as well as validated. So whenever the patient, suppose, comes to you at, like in these 2 years, past 2 years of corona, many patients, they came after 20 weeks and onwards. So we should definitely ask only those labs, those who have the validated software till 22 weeks 6 days, and try to send the sample to them. So it's actually, see, percentage wise maybe a bit, maybe I'm not very sure of the percentage detection rate in the difference of till 20 weeks or 22 weeks, but this should be very important, that you should send the sample before and with a prior inquiry from the lab whether you have the appropriate software that can calculate till 20 weeks, or the patient is at 21 weeks 6 days, so we should go for this. That is very important. And one thing is, 14 weeks is something a very gray zone. It's see, the dual marker is 13 weeks 6 days, and from 14 the quad starts. So what we have experienced in our OPD practice, that 14 to 15 is a very gray zone for quad, and preferably one should go for a sample collection for quadruple beyond 15 weeks, roughly somewhere 15 weeks, 2-3 days, 4 days, or to be honest 16 weeks. So 16 to 20 weeks 6 days is what the most lab, they have the softwares, and the recent all the softwares, the Delphia and all, they go up till 20 weeks. The older platforms, Prisca 5, they were doing till 21 weeks 6 days or 22 weeks, but the latest all the platforms, they are doing till 20 weeks 6 days only. So we try to collect the samples between 16 to 20 weeks 6 days, because early gestation taken like 14-15 weeks mein, moms are, we have seen most of the time the moms are very erratic, and many times we get more of high risk cases like that. So the appropriate time, maybe that is my experience, or it is with other obstetricians also, but what I suggest is roughly around 16 weeks and then till 20 weeks 6 days. That is it.
I think that's all for the question answers.
Thank you so much, ma'am. I now request Mr. Avinash Chandra, the Assistant General Manager from OnQuest Laboratories Limited, to please give the vote of thanks. Over to you, Mr. Avinash.
Thank you, Kashish. On behalf of OnQuest team, I would like to thank all the speakers, Dr. Poonam, Dr. Nidhi, for excellent presentation and coverage of the topic.
Dr. Avinash, please switch on your camera.
Definitely, ma'am. So also would like to thank Dr. Glossy for moderating this session, and would like to thank all the prestigious doctors who have attended this webinar. And definitely we will meet next time with another topic, another interesting one, with other distinguished guests and speakers. So thank you so much for joining us, and good night to all. Thank you so much. Thank you. Also would like to thank Kashish and Kavina team for moderating and executing this event very well. Thank you so much.